Funding for this podcast is provided by the Aortic Vascular Division at Cook Medical.
Welcome to Texas Heart Institute podcast on living legends and luminaries in endovascular medicine. My name is Zvonimir Krajcer. I'm an interventional cardiologist at Texas Heart Institute and Baylor College of Medicine in Houston, Texas. Our guest today is Dr. Coselli. Dr. Joseph Coselli is an executive vice chair of Michael E. DeBakey Department of Surgery, and he holds the Cullen Foundation Endowed Chair and is professor of Division of Cardiothoracic Surgery at Baylor College of Medicine in Houston, Texas. His undergraduate education was at the University of Notre Dame, and his degree was in biology, Bachelor of Sciences. He attended medical school at the University of Texas Medical Branch in Galveston, Texas, and his postgraduate training continued at Baylor College of Medicine in Houston, Texas, followed by residency in general surgery and also residency in thoracic surgery at Baylor College of Medicine. He was mentored by leading legends and pioneers in aortic surgery such as Stanley Crawford and also Denton Cooley and Michael DeBakey. Currently, he serves as Associate Chief of Cardiothoracic Services at Baylor College of Medicine at St. Luke's Medical Center, which is located in Texas Medical Center in Houston, Texas. He also directs Aortic Fellowship program at Baylor College of Medicine. Dr. Coselli specializes in clinical evaluation and surgical treatment of diseases of the aorta. He has performed over 10,000 aortic aneurysm repairs and also including over 3,800 of thoracoabdominal aortic aneurysm repair. He is world-renowned in this field and has published more than 600 medical manuscripts and delivered over 950 presentations in more than 39 countries. Dr. Coselli is an innovator and leader in the field and is highly experienced in complex aortic aneurysm repair, such as patients with connective tissue disease, as well as emergent repair that is performed in patients with conditions such as acute aortic dissection and also aortic rupture. Dr. Coselli currently serves as the director of the American Board of Thoracic Surgery, and he has served as the president of several surgical societies, including Michael E. DeBakey and Denton A. Cooley Surgical Society. We would like to welcome Dr. Coselli to our Texas Heart Institute podcast on living legends and luminaries in endovascular medicine. Dr. Coselli, it's a special pleasure to have you here with us to join us for the Texas Heart Institute podcast in the program Living Legends and Luminaries in Cardiovascular Medicine. Thank you very much for being part of it.
It's an honor, but I'd like to stress the living part.
Right. I would like to ask you a question. What really influenced you to pursue a career in medicine?
Well, it's tied to the Texas Heart Institute, actually. I was born, raised, and grew up here in Houston. We lived in Bel Air, and my folks eventually lived down in Sharpstown. My father was an attorney, and the only doctor I knew was a family practice doctor, kind of a general practitioner, and he was a pretty interesting character. So when I went off to college, my plan was to go to law school because that's what I knew. And so I spent my first year taking courses that I thought would help me get into law school. And since I had sort of a proclivity in math and physics and biology and sciences, I loaded up my schedule with that sort of thing. And then I was, in between my first and second year in college, back here in Houston, I needed something to do. The previous job I had, the company sold and was shut down. So I had a cousin that was one of the head nurses with Dr. Cooley. And at that time, they would take, so this is like 1971-ish, they would take some kids during the summer to kind of work with the group at the Texas, the building had just opened a few years before that. And so he took me on. I became one of the summer students, as they called him. And he put me with a fellow by the name of Charlie Reed, who was the head of the pump team. Charlie Reed had been in, I believe, Oklahoma or Ohio or something, and when they developed the pump school here, Dr. Cooley had brought him. So I spent that summer working with the pump team. It was fascinating, but between setting up and taking down pumps and cleaning things up, I had some time, and I would look over the ether screen. The first operation I ever saw in my entire life was Dr. Dan Cooley doing an arch aneurysm on a patient. I think probably had syphilis, but that's how that goes. And after that summer, I leaned towards going into medicine with the idea of actually going into surgery.
Yeah, so it's interesting that you mentioned Charlie Reed. When I started here at Texas Heart Institute, I remember him clearly. Unfortunately, he died of peripheral vascular disease, but he was a true gentleman and a very capable person. But I wanted to ask you, you are really fortunate to be born and lived in the mecca of cardiovascular medicine when we talk about the DeBakey, Stanley Crawford, and Dr. Cooley. So it's a unique opportunity that very few people in your field had. So I would like to ask you, maybe you can tell us a little bit about what was it working like, let's say, with Dr. DeBakey when you were at Baylor and you were at Methodist Hospital. Maybe you can give us some anecdotes and some of experiences that you had working with him.
Well, I can share a few of them with you, but let me just tell you a little bit about how I got there. Again, it was Dr. Cooley. At that time, his associates were Grady Holman, Don Wukash, Jack Norman kind of came and went a little bit, George Rule, et cetera. And Frank Sanford was one of the associates. And I noticed a pattern among those guys that training in Dr. DeBakey's program was kind of how they got to be where they were. So I thought that might be a pretty good idea, and Dr. Cooley certainly didn't discourage it. When I was in medical school down in Galveston, I was able to do that in 3 years, and I had an externship. I had a month or so, and so I came again to the Texas Heart Institute, and Dr. Cooley certainly didn't discourage me from going to Baylor. And they took me into at that time, to go into cardiac surgery, you had to do 5 years of general surgery. And then you had to do 2 years in the cardiothoracic training program. So that's what I did. And fortunately, Dr. DeBakey and I got along pretty well. He didn't say a whole lot to me for a long time, but apparently at those days, that if he had much to say to you, it wasn't a good indication. So I kind of asked somebody one time, I said, he doesn't say much. And they said, well, it means he likes you okay, don't worry about it. So it was a top-down structure. He had probably as many as 30 patients in the ICU and many as 70 or 80 patients of his own in the hospital. And when you're working with him, at various times you had to keep track of either one of those two groups, which was kind of a special experience as a very junior general surgery resident, you were assigned to his service. Every morning you met with him, and you presented all the cases that had come in the night before. If it was on a Monday, it could be as many as 15 patients you had to present to him in a very precise, accurate way. If you got off track, it got interesting very, very quickly. And then at the end of the day, you met with him again. It was just he and you. And patients had studies during the day that you all had planned. And they would have cardiac caths, they would have angiograms, et cetera. We didn't have, anything digital like that. We had the old films on Todge and flat plate X-rays, and he had a view box. and whatnot. He was a very, very tough, serious taskmaster, but once you learned what he wanted and how he wanted it, and you managed all of that exactly that way, you never had any problems with him. There's nobody spends that much time with him without, at least some interesting things happening from time to time. When he would make rounds, there would be a bunch of people going along, thoracic resident and some fellows and that sort of thing. But for the most part, it was just you and he, and y'all led the thing, and then the others were kind of just listening and trying to pay attention, et cetera. And I remember one, you would open the next door and you would say, Mr. Smith, door bed, 3 days post-cab, doing great. Mr. Jones, window bed, 4 days post aortic valve, about ready to go home. And one time he got ahead of me and he opened the door and he was looking straight at a mop. He turned around and looked at me, and I guess I was probably as white as this coat. He smiled a little bit. We just moved on. He was okay with that. Another time, he was moving fast, and we had a lot of patients. And one of the rooms had 2 patients, and one of them was Jimmy Howe's patient. So I told him it was, Charles whatever in the door bed, he's 3 days post-cab, and Dr. DeBakey went in there, and he turned and talked to the other guy. Of course, I was just like a general surgery intern, and my patient, I kind of waved at him, and he kind of kept quiet. He thought the whole thing was funny, and the other guy was so honored to be talking to Dr. DeBakey, he didn't say anything. So when we left, I went back and talked to him, and everybody was good about it. There were things like that happening all the time.
One of the things that I've heard from your colleagues that went through the training with Dr. DeBakey, that one of the toughest parts was spending 2 months, day and night, in the intensive care or surgical recovery room. How did you survive that? Because some of the cardiothoracic surgeons didn't make through it, and they had to leave the program.
Yeah, there was 3 levels of how that ended up. It was either 2 months or 3 months, depending upon the timing and depending upon how many people that year. You either made it fine, that was one outcome. 2, things didn't go well, and you would end up getting pulled, and you go to George Jordan, who was at Ben Taub, and you were basically fired from the service. They would bring somebody else in, and you just kind of picked up somewhere else, and they got you kind of out of Dr. DeBakey's line of sight for a while. And then the third possibility is if Dr. DeBakey and you did not see eye to eye, and he didn't think you had a very optimistic future in the specialty, and he would see to it that you moved on and did something else. We had one fellow I remember in my year went on to do gynecology, another one went on to do psychiatry, et cetera. They moved quite a bit. There was probably about 13 of us in my year started, and only 3 or 4 of us finished.
Amazing.
It was a pyramidal program in
because
those days.
I remember actually several of Dr. Cooley's associates started with the DeBakey and ended up here, including Sandiford as well.
Sandiford trained there. George Rule trained there too.
Right.
George Rule stayed on the faculty for a while.
Right.
There was a fellow by the name of Ken Maddox who became sort of the icon fellow that ran Ben Taub, but George Rule preceded him a little bit.
Right.
Yeah.
Right. So
I remember that there was a fellow I think he fell out of a 2nd-story window over in River Oaks. It was the husband of a lady by the name of Candace Mosler. So this is about 1972. And no, it was a little before that. And George Rule was over there at Ben Taub, so they brought him to Ben Taub, and George Rule took care of him at first, and then passed him on to Methodist, and Dr. DeBakey took care of him, and Ms. Mosler gave both of them Ferraris.
So another great, remarkable surgeon and individual that was associate of Dr. DeBakey was Stanley Crawford, and you worked with him quite a bit as well. And he had a tremendous reputation as one of the best. He specialized mostly in cardiovascular or vascular type of procedures, what you are known for at the present time, thoracic, thoracoabdominal aortic aneurysm. That was his forte. So how was your work with him, and what would you say, what were the impressive and the strongest points as far as Stanley Crawford is concerned?
Well, he was, Stanley was a piece of work. It was a great honor. When I was in my last year in my thoracic surgery training, we rotated at that time through Riyadh, Saudi Arabia. And I had a job lined up in private practice, basically, before that. Hadn't signed on the dotted line yet. And Stanley Crawford had an associate who was going to be leaving and needed to fill that spot, and asked me if I would like to stay on and work with him. And I thought, since I had only spent 3 years in medical school and cut a year out of grade school, so I had, in no research years, I was kind of a little bit on the younger side, and I thought a little extra experience would be great. So that said, I'll do that for a year, and it turned out to be 7 years. He was also a very, very serious guy, but was different. With Dr. Cooley, you'd go hunting and play golf. With Dr. Crawford, he didn't play golf, but he did hunt. He grew up in a small town called Evergreen, Alabama, during the Depression, and so hunting was kind of his thing, and particularly birds. He would hunt birds out on the west side of west of Houston, and also go down into the South Texas and into northern Mexico. But he was the godfather of thoracoabdominal aortic aneurysms. Bud Frazier was fond of saying that Dr. Cooley was really much of a very well known and probably one of the greatest artists in the field of cardiac surgery probably has ever lived. So he took care of that end, and Dr. DeBakey was as well known as anything else for his vascular surgery, and really did a lot of abdominal aortic aneurysms, and nobody wanted to mess in that no man's land in between, and so Bud Frazier points out that Dr. Crawford staked that out and made a name for himself in that area, and we've continued on.
Until you came
We continued on with that work. He did 1,509 thoracoabdominal aneurysms, Crawford did.
So now the third remarkable individual that you already mentioned a little bit about was Denton Cooley. Can you tell us a little bit about your personal experiences with him? What was unique about the way he practiced cardiothoracic surgery, and what did you learn from him the most?
He was a Southern gentleman. He had also grown up. Was born and raised here in Houston. His father was a dentist, and his father helped establish the dental school here in Houston. And when he went to Johns Hopkins and spent some time overseas in the military after that, and spent some time in London with Lord Brock, etc. But ultimately came back to Houston, and the place to work at that time would have been Dr. DeBakey. So Dr. Cooley came back to Houston in 1951. I got to know him, like I said, when I was freshman in college, and kept in touch with him. We would play golf from time to time, went hunting with him a number of times. When I was over at Methodist, before I came over to St. Luke's, we under the table, I wouldn't spend any time talking to Dr. DeBakey about my relationship with Dr. Cooley. I don't know if he knew anything about that or not, but I did know that Dr. Crawford was neutral. So that was good, which was helpful. And he one of the two major organizations in thoracic surgery is the STS, and the other one's the AATS. And although I eventually was associated more with the AATS, Dr. Cooley got me on a bunch of the committees and programs and things with the STS, and we would meet each other for these things and have dinner, and he was and run into each other at programs around the world. It was a great relationship. I still remember when I was a student watching him do surgery, and I've had the opportunity to watch an awful lot of people do cardiac surgery. he's the Michael Jordan, the Tiger Woods of cardiac, or Jack Nicklaus of cardiac surgery. It was truly an awesome thing to see. And in fact, when people would come over to Methodist, from elsewhere, sometimes from around the world, to watch Dr. DeBakey and Dr. Crawford do things, if I got a chance to talk to them, I'd say, listen, while you're here in Houston, if you really want to see something, go over and see Dr. Cooley. He'll welcome you because he welcomes everybody, and you'll be quite pleased that you took an afternoon and watched it, because it's rather remarkable.
Now, I would like to ask you a little bit of a provocative question, and it's all related to the individuals we just talked about. When this feud happened between Dr. DeBakey and Dr. Cooley, of course, this was very uncomfortable for the whole community here, and of course for both of them as well, particularly for Dr. Cooley, because this affected him to a great deal. Can you tell us a little bit, how did you perceive and look at this scenario, what was evolving here? Of course, it was all over the news media. The books were published on it and so on.
Yeah. The story goes back to April 1969 when Dr. Cooley placed a total artificial heart in a gentleman by the name of Haskell Karp. Couldn't get him off pump. He had bad coronary disease, a left ventricular aneurysm, etc. And then he had the total artificial heart for a few days, and then had a heart transplant, and then passed away shortly after that. And Dr. DeBakey was out of town at the time and did not look favorably upon the first artificial heart being placed when he was out of town, and there was a lot of discussion as to whether it was DeBakey's heart or Cooley's heart.
Or Liotta.
Liotta was involved in both of them. Dr. DeBakey was working with Baylor and the NIH on his heart, and Dr. Cooley, according to him, was working on a similar program with Liotta, but working with some engineers and things at Rice. And Dr. Cooley was censured, but Dr. DeBakey actually stayed out of the censorship. He wouldn't testify into that or provide any records for that. He did stay out of that, which I thought was interesting. But they didn't speak to each other for a little over 40 years as a consequence of it. And I got to watch a lot of it firsthand, spending time with both of them. I think Dr. Cooley was not as acrimonious about the whole situation as Dr. DeBakey was, but there wasn't anything Dr. Cooley could do to mend those fences. But Dr. DeBakey in 2006 or 7 had a type A dissection, and George Noon operated on him. I was already over here, and he survived it. And after that, Dr. DeBakey softened up, and the two boys finally got back together. I sat with both of them at a meeting one time, just the three of us, and they were talking to each other like they were old friends and old stories and what have you. Dr. DeBakey had Dr. Cooley inducted an honorary into his surgical association, and vice versa. When Dr. Cooley came over, we gave him a book. There was a bound volume of all the publications that they did together, and then their first paper, which was on transverse aortic arches. Some of those Dr. Cooley had actually done while he was at Hopkins. It was the first paper they published together. We gave him a framed copy, and Dr. DeBakey asked Dr. Cooley, "You're going to hang that in your museum or in mine?" Which was kind of tweaking each other. But they did make up, actually, and it was quite a thing to see. It's there's been a lot of so-called rivalries in medicine. You're going back to a variety of different things over the years, and most famously, with the vaccines, but. It was amazing to have a first-hand front seat to that whole thing.
Yeah, actually, this reminds me, we interviewed Frank Veith for one of the podcasts, and he wrote a book about his experience. He's now 95 years old, I believe, and he wrote a book. The title is Medical Jungle, as far as rivalship is concerned and so on. So this happens over and over again. But
Frank's he's doing great, by the way. He and I text each other probably
Right.
2 or 3 times a week.
Right.
He's doing very well.
So I would like to go now back to your career. We talked enough about the great ones, but you are another great one that has achieved so much. I believe, if I'm correct, you probably did over 10,000 operations in your lifetime, right? As far as cardiothoracic type of procedures are concerned, and close to like 3,900 of thoracic and abdominal aortic aneurysm, right?
Well, actually, yeah, that's close. It's actually more than that.
I'm sorry.
It's probably close to 20,000.
Oh, is it?
The 10,000 is probably aortas.
Aortas.
And I've done over 3,800 thoracoabdominal aneurysms,
Right.
and probably a similar number or more of aortic roots and ascendings and arches. And so if you throw in the abdominal aortic aneurysms, which we used to do back before EVAR, and then there's hundreds and hundreds of descending aneurysms, the number gets to be quite
pretty large.
interesting. Yeah.
So I think with those numbers that you just mentioned, I don't think there's anybody anywhere near that at the present time, particularly as far as thoracoabdominal aneurysm repair is concerned. But not only that you have done so many thoracoabdominal surgical repairs, but you have done a huge number of endovascular or hybrid repairs of thoracic and abdominal and thoracoabdominal aortic aneurysm. So you are truly unique from that point of view.
It's a totally different journey. Yeah, I've done over 1,000 endovascular things. When I was at Methodist, and Gore had the first clinical trials on the Gore graft for the infrarenal abdominal aorta. I was the PI for that trial for Houston.
Mm-hmm.
And then when they did their TVAR, I was the PI for that as well, and got involved with Medox and a few of the other companies. And then when it came around to TAVR, I was the PI here for the core valve. So I started doing wires and catheters a long time ago, but it's pretty hard for a surgeon to be as skillful as the cardiologist, such as yourself, with these things. But we can still do a few of them.
So, but you also participate in a lot of other different device investigations and so on with some of the Terumos and the other companies as well. It's not just what we mentioned so far.
Yeah, there's a hybrid device for the transverse aortic arch that extends with an endovascular portion down into the descending. It's called the Thoraflex.
Right.
It became available a couple of years ago through the FDA. It's interesting. Became available in Europe in 2012, but didn't become available in the U.S. till we got that trial and pushed it through the FDA. It was available here in late spring of 2022, and I was the international PI for that trial.
Mm-hmm. Mm-hmm.
And
So
I was involved in a lot of valve trials as we go on, trifecta, and there's,
all the good ones and all the bad ones.
all the good.
So
You got to kiss a few frogs once in a while.
tell us what is still inspiring you to do as far as the things that you would like to achieve in your career before you say, well, I have done enough.
Well, I don't know if you ever get to the point where you say you've done enough if you have the DNA and the sort of psychological makeup of a surgeon, but I can tell you what gets me up every morning is that we're teaching, and passing on, to the so-called next generation, through the thoracic residents, the vascular residents, general surgery residents, because the one thing that we know for certain is that things are going to be different in 10 years and 15 years and 20 years. For our predecessors who had to invent, cardiopulmonary bypass and valves and vascular grafts like Dr. DeBakey, things were just draconianly different than when they were training, for goodness sakes, and throughout their careers. When I was well into my career when endovascular work came along, or so we're still involved in trying to push that envelope, which is exciting. One of the most rewarding things, as I think about things, is that I've got some people that I've trained that have been extremely successful, around the world. The head cardiac and aortic surgeon at Northwestern is Chris Marolesi, which we trained. Lynn Jardy's at Cornell. He followed Wayne Isom, and he's the head of probably one of the busiest heart surgeons in New York, and that's because he spent a year down here learning the aorta. There's a famous surgeon by the name of Tyrone David, who is known for the David operation, the valve-sparing route, and he stepped down as head of that division, and the person that took it over was Maral Oznonion, and she got, he's an aortic guy, and she really learned a lot of her aortic surgery spending a year fellowship with us. So people like that around the world, the number one aortic surgeon in Japan's a guy that we trained, et cetera, and so that's really one of the highlights of a career, to have people like that be very, very successful.
Well, with your recognition and your achievements, you travel a lot. You continue lecturing and participating at different meetings. You almost once a week you go somewhere. I know that because it was very difficult to schedule this podcast with you, and I think you've probably been on almost all of the continents, if not all of them. I don't think that you gave a talk at Antarctica, but I wouldn't be surprised.
I missed Antarctica. I got all the rest of them, though. Yeah.
So one very important question, let's say 10 years from now, when you and me are going to be retired somewhere enjoying sunshine and taking it easy, what do you think would cardiothoracic and endovascular medicine is going to look like if you would have to look at the crystal ball and say, well, this is how it's going to be done in 10 years from now?
Yeah, let me go back
I'm talking
Sure.
about thoracic, abdominal, vascular, and so on.
Sure. Well, you talk about traveling. I've had the opportunity to operate in 11 countries outside the U.S., places like Poland, Turkey, Russia, and it's been an interesting journey. And we're still lecturing, and I'm still involved in a lot of programs, both as a speaker and as an organizer. So you're asking about the future, and that's almost impossible to predict, other than it's going to be, for certain, a lot different than it is today. Endovascular work with descending thoracoabdominal, abdominal aorta has the footprint is just almost every day gets larger and larger and larger. There are problems still, and a lot of them are device-related, materials-related, technology-related. But I think anybody who's taken the position that ingenuity and innovation is, if they think they're not going to be able to solve those problems in the future, they've always been proved wrong. And so I think we're going to be looking forward to the day where the open operation is going to be a very, very rare exception. That many of the issues now that we still do open because the endovascular situation just hasn't quite gotten there, even though it dominates actually the field now, they're going to be solved. It's going to be endovascular. I don't think there's any question about it in my mind.
What about the robotics?
Robotics in for thoracoabdominal and again that's. It's going into the cavity, and I think the work is going to be done with wires and catheters inside the arteries, not more than robotic. Robotics in cardiac surgery has been very valuable in things such as mitral valve surgery for sure. And the guys here did a robotic heart transplant not too long, just literally in the last couple of weeks. So it has a place, but for aortic surgery, probably not so much. I think it's going to be solved a different way. Endovascular.
So one thing that you mentioned, and I absolutely agree with you, is there are still unmet needs, particularly as far as materials are concerned. When you start thinking, when Dr. DeBakey created the first graft, using his wife's sewing machine and a Dacron material that he bought in the store for sewing materials. That Dacron is still being used. And so that was more than 75 years ago,
Yeah.
roughly. And so there is a need for newer materials rather than keeping the same type of products that have certain benefits, but also certain deficiencies.
At that time, the homographs really dominated, but people were trying things such as Teflon, but it was too inert. Orlon and nylon are hydrophilic, which is a problem. Dacron turned out to be just for durability and just the right amount of inflammation to help healing. The biggest advance in grafts was again back in the 1980s, when we had materials to seal the graft so it wouldn't leak through the interstices, albumin, gelatin, collagen, etc. But outside of that, there's been no major advances in graft material. The other alternative is Gore-Tex, but for a lot of things, Dacron's still superior. There are people and companies and things trying to work on improvements in the material we use for replacement of the aorta. I think they better hurry.
Mm-hmm. Right. In early stages, I remember from Dr. DeBakey's and Cooley's early publications, joint publications, human cadaver grafts were being used because no other materials were available.
Well, they published the first ascending aortic successful replacement. It was a homograph. First
Right.
descending, it was a homograph.
Right.
Of course, they didn't do the first infrarenal abdominal, but they had a good series of homographs in that. I think they did the first successful ruptured abdominal aortic aneurysm, and that was with homograft. And the arch operations were also done. The ones that weren't saccular were done. The ones that were replacements were early on were homografts as well. But once Dacron became available on the shelf, it was the homographs were set aside. Still used occasionally for infection, but that's about it. And well, for the Ross operations, used on the pulmonary side. It's used a little bit more in children, but for adults, it's mostly Dacron now.
Well, as a last comment, it's amazing, and of course, we at Texas Heart and St. Luke's Hospital and Baylor College of Medicine greatly appreciate you being here as a leader and part of this cardiothoracic team. You have made a full circle. When you were a student, you were here. Then you went to Baylor as Methodist and so on, and now you're back to where you started. So thank you for coming back home. It's a pleasure.
It's an honor. Thank you. Appreciate it.
Thank you to the Aortic Vascular Division at Cook Medical for sponsoring this podcast today.